Okay, I think it's time to start. It's really my great pleasure to be able to introduce Dr. Michael Davidson today. He's someone I've been aware of his work for a long time and admired him, but have never had the opportunity to actually meet him. Dr. Davidson is a clinical professor of medicine and director of the lipid clinic at the University of Chicago Pritzker School of Medicine. He also serves as Chief Medical Officer and Executive Vice President of OM3 Pharmaceuticals, which has been recently acquired by AstraZeneca. He earned his medical degree from the Ohio State University College of Medicine in Columbus, Ohio, and then he did his residency and fellowship at Rush University Medical Center in Chicago. Dr. Davidson maintains a very active research program that encompasses both pharmacological and nutritional clinical studies. He's conducted extensive research in the areas of statins, novel lipid-lowering drugs, and non-pharmacologic interventions to improve cardiovascular disease risk factors. He's coordinated a mind-boggling over 1,000 clinical trials and has published in excess of 300 articles and written 2 big books on lipidology. Dr. Davidson is board certified in internal medicine and cardiology and clinical lipidology. He's a fellow of the American College of Cardiology and the American College of Chest Physicians. In addition, between 2010 and 2011, he served as president of the National Lipid Association, and while doing all that, for the past 10 years, he has been included as one of the best doctors in America, and in 2010, something I'm very impressed with, he was named Father of the Year by the American Diabetes Association. So please join me in welcoming Dr. Davidson.
Good afternoon. It's a great pleasure to be here. I'm delighted to be speaking to an audience of nutrition enthusiasts, because I usually talk to cardiologists who just all they want to do is put in catheters and open up blocked arteries and treat arrhythmias and things like that. So it's a great pleasure to be here. So I'm going to kind of go through with you, my last couple of years of research relating to omega-3s, and while we're on the cusp of starting a very important cardiovascular outcome trial, which I'll explain to you in a minute. We hope to have our first patient in November, so we're very close to getting started. And I think it's going to be finally one of the important landmark trials to establish the benefit of omega-3 therapy and also for lowering triglycerides to reduce cardiovascular risk. So let me begin by showing you a slide from the different amounts of omega-3s in breast milk, which I think is a pretty good kind of correlate to plasma levels or red blood cell levels, and I'll show you another study later at the end. But you can see that, that a lot of us assume that the amount of omega-3s in our blood or breast milk or in our tissues relate to the intake of fish in the diet, which is true. I mean, you can see around the world, Japan has the highest levels, in North America has the lowest levels of breast milk omega-3 levels. And among the intake of omega-3s, based on the MESA trial, which is a U.S. trial, Hispanics have the lowest fish intake of any of the different ethnic groups studied: Chinese, African Americans, Caucasians, and Hispanics. Hispanics have the lowest amount of fish intake in the United States. So I want to, though, move beyond intake and talk about genomics and how that relates to omega-3 levels, because there's a very important consideration that I think is often overlooked when the research looks at omega-3 levels in the blood. There's also a very important genomic effect of omega-3 levels. Just in general, the genomic revolution has been a very exciting story to see unfold. In cardiology, we have a new therapy we're very excited about, called a PCSK9 monoclonal antibodies. This was discovered in the genomic revolution. They determined a gain-of-function mutation in 2003 causing very high cholesterol. They found a loss-of-function mutation of PCSK9 associated with very low levels of cholesterol. Discovered it was a secreted protein that could be inhibited by monoclonal antibodies. And now, just about a little more than 10 years later, we have a very effective therapy, a monoclonal antibody, to lower LDL by 50 to 70%. And we'll be soon having FDA approval. And there's 3 major large cardiovascular outcome trials underway looking at this as a target. So genomics has been a very exciting way to evaluate new targets, to understand how those targets might affect cardiovascular risk through looking at if the surrogate itself is associated with cardiovascular events, and even more so if it's a lifelong exposure to that effect. And that has led to a lot of different targets being evaluated for cardiovascular risk reduction. So here's the list of genes associated with lipids, just LDL, HDL, and triglycerides. And I'll come back to this later, but it's a consistent story that LDL cholesterol-related genes, if they're high, the risk is lower. If the LDL levels are causing low LDL, the risk is lower. If they have high LDL, the risk is higher. So it's a very consistent finding. Every gene associated with LDL is correlated with cardiovascular risk, either high or low, depending on what the impact of that gene is on LDL. So it's a very solid story that LDL is causal for atherosclerosis for that reason. And so the lifelong exposure of high LDL increases risk even more than expected. And the other is true also. Lower levels lifetime protects long-term to a greater degree than expected. The HDL story is very different. It's basically equivocal. There's no consistent effect of HDL genomically on either risk or benefit. And that's led to concern about whether that's really a viable target. And I still think it is, but it's another lecture to talk about HDL. And then we have triglycerides, and I'll show you the data. Just recently, it's been shown triglycerides are very similar to LDL. High triglycerides genomically, high risk. Low triglycerides genomically, low risk. And that has refocused the thinking about triglycerides as being now an important causal factor for cardiovascular disease. But what I want to talk about, though, are the genes that relate to omega-3 and other polyunsaturated fat levels. So if you notice on this list, the FADS genes comes up. Here's PCSK9 as an example, but you see FADS here for LDL, HDL, and for triglycerides. It's a gene associated with all of those lipid parameters. So what exactly are the FADS genes? You're a nutrition audience, so it's not as hard to explain this than it is to explain it to cardiologists, but it's the genes that code for the desaturase enzymes, delta-6, delta-5, the conversion of short-chain PUFAs to long-chain fatty acids. So you have it for both the omega-6 and the omega-3 side. You can see that EPA is formed by the same desaturases as arachidonic acid. And so this is these polymorphisms are actually quite potent, and I'll show you that data. So this is, I think, well known to you too, that when you have arachidonic acid as a precursor, a lot of different inflammatory cytokines. So here's the data from the meta-analyses that show when you look at PUFA levels, that the FADs show up very strongly as having an effect on the different omega-3 levels. So this is a GWAS trial demonstrating that. So there's just one example of the genes associated with high triglycerides. The FADs comes up as one of the most important genes for its effect on triglyceride levels. So when you have the minor allele, which I'll explain to you is a major allele for Hispanics, you have a higher risk of triglycerides, significant risk for having elevated triglycerides. So Hispanics. So the Hispanics are a growing part of the U.S. population. And if you look at their prevalence of hypertriglyceridemia, it's quite markedly elevated compared to Caucasians and especially compared to African Americans. So here's the here's the Hispanics, here's the Caucasians, and here's the African American. This is by age. This is prevalence of hypertriglyceridemia, greater than 150, greater than 200, and here's greater than over 500. So you can see that it's very, the reason why it drops off here is that the death rate is so high for these patients. But at age 50, about 9% of Hispanic males have triglycerides over 500. That's an astounding percent if you think about it from that perspective. So it's a very prevalent disorder among the Hispanic population. So the question is it due to low fish intake, or could it also be due to their FADS polymorphism? It turns out that 80% of Hispanics have the minor alleles for FADS. So they are relatively poor converters of omega-3s from short chain to long chain fatty acids. They have lower levels of arachidonic acid, but also lower levels of omega-3s. And this is associated, as I mentioned already, with hypertriglyceridemia. The triglyceride levels are more elevated when they have this polymorphism. Now the thing is, in some studies, but not all, this polymorphism is also associated with greater risk of cardiovascular disease. And the reason I think it's difficult to sort it out because it's a diet genomic interaction. And so when you think about it, and then also understanding prevalence of cardiovascular disease in the United States for Hispanics has been a little bit challenging. They have been underrepresented in a number of trials, and so we're trying to catch up on that as quickly as we can. But nevertheless, it's linked to high triglycerides, and in some studies, linked to that same polymorphism, linked to high risk for cardiovascular disease. So here's what I believe is going on with the Hispanic population. They have a high carbohydrate intake and a low fish intake, so therefore they get a lot of they have a lot of substrate for fatty acid production, and they have low amounts of omega-3s in their diet. But they also have this polymorphism, and they are poor converters of short chain omega-3s to long chain omega-3s, and so they have less amounts of omega-3s in their liver that can suppress triglyceride production. So they end up with increased triglycerides, low HDL, increased risk of fatty liver, NASH, heart disease, diabetes, metabolic syndrome. That's their genomic issue relating to FADS polymorphism. So 80% of Hispanics carry this polymorphism. So they have, again, an unfavorable ratio because of low EPA, but also lower AA levels. Then we have African Americans, just the opposite issue. They're hyperconverters. 80% of African Americans have high conversion of short chain to long chain fatty acids. They have increased production of AA. They have higher AA levels, but also higher EPA levels. So both of them have unfavorable ratios, but for different reasons. The Hispanics have low omega-3 levels, low short chain omega-3 levels, and the African Americans due to high AA production due to this polymorphism. It's called now what it's been called the desaturase hypothesis, that many of the discordance between different diseases in certain populations are relate to these differences in desaturase activity between especially between the African Americans and Hispanics, representing two distinct populations, one with high triglycerides, the other with low triglycerides in general. This is from this is looking at the African American polymorphism. What they showed in this study was that the more of the alleles that you have, the higher the arachidonic acid to linoleic acid ratio. So they're hyperconverters. So you can see the ratio goes up. It's associated with heart disease, with high CRP. So and then here's the hazard ratios for coronary artery disease in this trial. So the point here is that Hispanics get more heart disease, metabolic syndrome, diabetes for their inability to have conversion of short chain to long chain fatty acids because of low omega-3s. African Americans have good conversion, but they have a lot more arachidonic acid than EPA, leading to an adverse effect as well. but different risk factors. They have hypertension more so, which is we believe could be related to the higher arachidonic acid levels and vasoconstriction. They also have a lot more diabetes, but a different type of diabetes, more difficult to control and associated with much more severe both microvascular and macrovascular complications. So the number of alleles here again showing the prevalence of the CRP and cardiovascular disease. The more of these hyperconverter polymorphisms, the greater the risk of both elevated CRP and coronary disease. So I like this study. Again, I'm a clinical cardiologist, so I'll get to some of my own animal research, translational research, but it's been very challenging to look at omega-3 animal studies because you have to give so much of it and so forth. But what they did here was they actually gave the gene that can convert omega-6 into omega-3, the FAT1 gene, FAT1 gene. And they showed that when you transfected the FAT1 gene into the liver in ApoE knockout mice, you markedly reduced atherosclerosis. So you convert omega-6 to omega-3, ended up reducing atherosclerosis. So I know this is not in vogue right now, but I'm still a fan of the ratio. And I know that's not where a lot of people are these days when it comes to the understanding of omega-3s. I've been heavily influenced by Bill Lanz, who was at the University of Illinois when I was a young researcher in omega-3s, and he was a big proponent of the ratio as well when it came to cardiovascular risk. So to summarize again, adverse ratios in African Americans, high risk, adverse ratios in Hispanics for a different reason, high risk, and now we have the evidence in animal models of flipping from omega-3, from omega-6 to omega-3, resulting in reduced atherosclerosis in this animal model on ApoE knockout background. So I want to bring this up. It's really hard for you to see this slide. I apologize, but this is the Brasky study that caused a lot of concern about omega-3s and prostate cancer. And I bring this up because it caused so much bad publicity about omega-3. A lot of people who are taking omega-3s stopped taking it, and it raised a lot of concerns. And they converted blood levels of omega-3s in this prostate surveillance trial with higher risk of cancer. And they implicated intake, but even though it was not an intake study, didn't even monitor intake. It was just blood levels were higher in those that had prostate cancer, and they didn't. In the conclusion, they said, well, fish intake now needs to be concerned about taking fish for this reason, and it caused a lot of publicity. We made the news, and a lot of people got concerned about taking omega-3s. But when you look at it from my perspective as interested in the polymorphism and fads, something interesting shows up. So yes, the highest quartile of omega-3s were associated with more risk of prostate cancer. However, also the highest quartile of arachidonic acid was associated with the increased risk of prostate cancer also. So I know it's harder to see, but the lower the arachidonic acid levels, the lower risk, the higher the risk. And so what I'm saying is that, to me, this was not a marker of fish intake, but they were picking up a marker of this polymorphism as being associated with increased risk of cancer. Obviously, we know that African Americans have a higher risk of prostate cancer. We know that that's a known fact, a much higher risk than prostate cancer. And I think that one of the key messages we try to explain is that Japan, which has the highest amount of fish intake, has 1/10 the prostate cancer risk levels of the African American in the U.S. 1/10, even though the highest fish intake. So it's not intake, but this polymorphism could be what's really explaining this difference. And so the other thing I want to point out in the study in Sweden, independent of all this, they implicated this same polymorphism in African Americans linked to prostate cancer. So a separate study linked to polymorphism, not the intake of fish, with polymorphism. So now a new study just came out, which you may have seen, where fish intake actually lowers prostate cancer risk. And it may be because it's inhibiting those desaturases, which is what it would do. And it turns out these desaturases themselves, in preclinical studies, stimulate prostate cancer growth. So I think that we have a lot of evidence to the contrary that that fish intake actually might reduce cardiovascular risk, and this polymorphism was misinterpreted as being associated with fish intake causing higher risk for prostate cancer. Okay, that's the polymorphisms, and I like to just make the final point that omega-3 levels are not just intake, but they're also genomically affected, and I'll show you more to support that later. So here's the next phase of my talk is really regarding the other issue that has been, I think, misunderstood about omega-3s has been that we think we give fish or fish oil capsules and we think we get absorption. It turns out that the absorption is quite variable depending on how you give the fish oil. And so this is just to show you that we have natural fish oil, which is 3 fatty acids attached to a glycerol backbone, and one of the 3 is omega-3s. And then most omega-3 supplements and pharmaceutical products are ethyl esters. That ethyl ester bond is very resistant to hydrolysis. We don't eat ethyl esters normally. It's not part of our normal diet, and it turns out that ethyl ester bond requires a lot more lipase activity to be broken down to the free fatty acids to get absorbed. When I first did omega-3 studies when I was a fellow in cardiology in the mid-1980s, we gave 20 capsules a day to lower triglycerides by 30%. And now, as I showed you, we're down to 2 capsules a day using a much more bioavailable form of omega-3s. So ethyl esters are poorly absorbed unless you have a high-fat diet to stimulate the pancreatic lipases. The free fatty acids we want to show you are already in the, quote, digestible form and are rapidly absorbed or readily absorbed, where they get re-esterified back into the triglycerides and the chylomicrons, and then they get liberated by protein lipase to the liver, where the site of action is reducing lipogenesis, hepatic lipogenesis. So this study we did to kind of demonstrate that principle is, again, in the 80s, there was some early data showing that free fatty acids were better absorbed than ethyl esters. Then another study came out saying it wasn't true, but they gave a huge amounts of ethyl esters, which may have stimulated the lipases. So we did a study looking at 4-way crossover, where they got 4 grams of Epanova, which is an ethyl ester, on a high-fat diet or on a low-fat diet. 4 grams of Epanova, which is a free fatty acid, on a low-fat diet or a high-fat diet. It was a 4-way crossover. So a free fatty acid, Epanova, or an ethyl ester, Lovesa, and this is the diet we gave them, a very high-fat diet or a low-fat diet, to see how they absorb the different omega-3s. So first of all, here's Lovesa, which is the ethyl ester. So on a low-fat diet, it's poorly absorbed. On a high-fat diet, it's well absorbed. So you need a high-fat diet to absorb the omega-3. By the way, both of them have about the same amount of EPA and DHA, pretty much exactly the same per capsule. So then we looked at, here's Epanova versus Lovesa on a low-fat diet. There's 5-fold better absorption, 5-fold bioavailability on a low-fat diet with a free fatty acid compared to a ethyl ester omega-3. Then on a high-fat diet, they're more comparable, but still it's better for the free fatty acid. Still significantly better, but much better with Lovesa on a high-fat diet. But Epanova is even better as a free fatty acid. So there's still even with a high-fat diet, there's better absorption with the free fatty acid form. So then that was a one-dosing study. What about chronic administration? We did a study in healthy volunteers that were given 2 weeks. The steady state was achieved of the omega-3s. And in this study, again, we saw on a low-fat diet, 5-fold. But this is EPA and DHA. This is EPA only, rather, but it's similar for EPA and DHA. 5-fold better absorption of omega-3s with Epanova compared to Lovesa. So here's the polymorphisms now. So turns out that in our study, it was a healthy volunteer kind of phase 1 study. Majority of the people involved in the study were Hispanics. So we were able to get a lot of people that were the TT polymorphism. They had the low conversion of omega-3s. And in that, as we showed, that they had the lowest amount of omega-3s. The TT, which is the major allele for Hispanics, but the minor allele. So the more they had the heterozygotes or the CCs, the major allele, but the minor, major allele for Hispanics, but also the major allele for Caucasians, they have the higher the level of omega-3. That's a very, very significant effect. This has been replicated by a number of other trials that the more you have of the different alleles, the more you have higher levels of omega-3s or lower levels of omega-3. So it's a very potent polymorphism. Just got to put it in perspective. I mean, we believe height is genetically determined, but yet of all the genes for height, we say maybe 5% difference in height based on all the genes that we have. This is a 30-40% difference in omega-3 levels based on these polymorphisms. So it's a very potent polymorphism associated with very different levels of omega-3 fatty acids. Well, what we found surprisingly, though, was that in those that have the TT polymorphism, there was even greater increases in omega-3 levels. So absorption was even greater when you had the TT polymorphism. And why is that? I can't explain, but it's been replicated in other trials as well. That when you have Hispanics that have this polymorphism seem to also get greater absorption of omega-3s when they do get it in the diet. Now there's an interaction here with lipids too, and so this is again the Hispanic polymorphism. So when they have lower fish intake, they have lower LDL levels, but they also have higher triglyceride levels. So they have lower LDL, higher triglycerides, lower HDL. That's what Hispanics have. Their LDL levels are lower than the general population, but their triglycerides are higher and their HDLs are lower. Then they have more metabolic syndrome. But the more fish they ate, the more the LDL went up and triglycerides went down and HDL went up. So they had a more of a conversion to a more normal type US pattern. And even giving omega-3s, they both alleles respond, but it looks like those that have the polymorphism might respond even better to omega-3 therapy. So this brings up the concept of FADs, diet, genetic interaction, and so this results in a clinical endpoint of CAD. So like I said, it's confusing about FADs and corn. We know it links to PUFA levels. We know it links to triglycerides and low HDL and LDL. But it's been harder to link it to cardiovascular disease because I think you have to explain as well the background diet and how that impacts disease, especially in light of the changing diet. And it's been hard with Hispanics because they've been underrepresented in some of these major observational type trials. All right, so that covers kind of like the genomic aspect and different formulations of omega-3s. I now want to focus on, okay, what do omega-3s do? They lower triglycerides and especially lower VLDL cholesterol. They don't lower LDL cholesterol. They change LDL composition. They don't lower ApoB very much. They don't affect HDL very much. But what they do is they lower VLDL remnant cholesterol quite well. And I'll show you the data on that. So the reason I bring this up is because the population in the U.S. is shifting from the Framingham data started in 48. LDL was like 160. Everyone 80% smoked. That kind of the typical was Clark Gable sharing a cigarette with Joan Crawford in this picture, and he died at age 59. And then fast forward, we have Tim Russer dying at 59 also, but on a statin, LDL below 70, triglycerides about 500, HDL of 20. And this is a very different type of pattern for dyslipidemia associated with increased cardiovascular risk. So here's the data on LDL, which obviously is a great target. We've been very effective. Cardiovascular risk are going down. Statins have been very, very important therapies. And the higher the risk, the greater the absolute benefit of statin therapy. So here's what now is being developed around the PCSK9 therapies. We're trying to lower LDL from 80 down to 40 in these high-risk patients. So 80 down to 40. And that's right here, 80 down to 40. So that's going to represent roughly about 10 to 15% relative risk reduction. Now for high-risk patients, it's a nice 2 to 3% absolute benefit. in those patients. But still, in my view, it's very important, and we're going to pursue it. It's going to be another great addition to our armamentarium. But from a relative risk perspective, it's a modest benefit. Where can we get even greater benefit? And I would argue that's on triglyceride lowering or remnant cholesterol lowering. So here's the PROVE IT-TIMI 22 trial, which established lower is better. And what this study showed was that two important points. One is that when triglycerides are high, above 150, LDL low or high, a little bit better when LDLs are low, but still very high risk, even with a low LDL cholesterol. And so that's point number one. Point number two is, yes, when LDL is above 70 or below 70, you can get a nice absolute benefit in this very high-risk population. Those with acute coronary syndrome. But even greater benefit could potentially be achieved with lowering triglycerides from over 150 to below 150. So that's where the absolute benefit potential is for triglyceride reduction. So what does that mean exactly? It really implicates not just LDL, but all the other lipoproteins that are triglyceride rich. And I want to focus especially on the cholesterol content of these other lipoproteins. So IDL, VLDL, chylomicron, remnants all represent the cholesterol content that's in non-HDL cholesterol minus LDL. So it's not just VLDL, it's not just IDL, it's other stuff in there as well. We don't have a good name for it. We need to come up with a better name, but right now you call it remnant cholesterol or non-HDL or triglyceride-rich lipoprotein cholesterol. That's my favorite name, triglyceride-rich lipoprotein cholesterol, but it's kind of a mouthful when it comes to how we define that other cholesterol. Now this cholesterol, it turns out, and you look at the data for this is a very important trial published in JAMA about March of 2012. The highest risk patient population on a statin was LDL below 100 but non-HDL greater than 130. So that implicates that other cholesterol is being very important in risk. Even more so, even 1.32 hazard ratio, even more so than have high LDL and high non-HDL cholesterol. So I'm going to advocate or argue that cholesterol is actually more atherogenic than LDL. I mean, let's put it at least as atherogenic. I'm going to argue it's more atherogenic than LDL. And I'm going to try to make that argument to the FDA as well when it think about approval of drugs to lower that cholesterol value. So getting back to the genomics, this is just to highlight again. So this is work by Sakar Katherson at Mass General in his work. I think changed a lot of people's minds about triglycerides. And what he showed in this study was that LDL is consistently shown to be a risk, high or low. When you correct for triglycerides and HDL, it's still a risk. HDL does not, though. When you correct for triglycerides and LDL, does not no longer predictive or no longer significant. But triglycerides remain relatively equivalent to LDL, 0.38 versus 0.36, and very highly significant correlations with risk, which I think has changed a lot of people's minds about the causal role of triglycerides, rich lipoproteins, in cardiovascular disease. In particular, there's interest in genes that affect LPL, lipoprotein lipase, ApoC-II, ApoA5, LPL itself. And so these are, I think, are other new and exciting targets of therapy. And I just want to show you ApoA5 for a second. So ApoA5, again, genomically linked to high triglycerides and also linked to cardiovascular disease, a very, very significant correlation between a causal role of ApoA5 deficiency linked to both high triglycerides and coronary disease. It's a relatively common polymorphism and explains a really significant part of the increased risk for cardiovascular disease. In fact, among hypertriglyceridemic patients, about a quarter of them have an ApoA5 polymorphism, which is a large percent of the population. So let me summarize. I recently drew this picture out. It's a little bit crude, but I think it explains it quite well. So here we have the liver with high and low triglyceride production. So when you have high production, you get a larger VLDL, more surface area. And so when you get more surface area, you get what's ApoC-III attached, which in my view inhibits ApoE binding to the heparan sulfate or LRP receptors, and you get less clearance of lipoproteins consequently, and so you get less LPL function, so you get this larger amounts of remnant cholesterol, remnant lipoproteins, slower conversion to LDL, and you end up getting a small dense LDL or very small dense LDL. So these are all associated with increased risk. Large VLDL, more remnants, small LDL, and low HDL as a consequence of that, all associated with increased cardiovascular risk. Now what do omega-3s do? So omega-3s convert you from a high TG production to a low TG production. So what omega-3s end up doing is you end up getting smaller VLDL, more ApoA5, ApoC-III is no longer, does not attach, you get better clearance, and you have larger LDL. So omega-3s convert you from this type of pattern to this type of pattern. LDL levels actually go up. LDL levels go up. HDL levels go up slightly, but the real effect is right here on the remnant cholesterol. That's what you're doing with omega-3 therapy. That's the profound effect you see with omega-3 treatment. So remnant cholesterol has been linked genomically as well in the Copenhagen Heart Study. This is what kind of got the ball rolling. A 2.82 hazard ratio for genetically elevated remnant cholesterol versus 1.47 for LDL. So they're both important, but looks like remnant cholesterol might be twice as bad as LDL cholesterol from a relative risk perspective. And this is the smaller trial, the Jackson Park study in African Americans, showing the same type of thing, but not quite as strong hazard ratios. But again, IDL remnant cholesterol is showing up as one of the strongest predictors of cardiovascular risk in this other trial. So one of the main kind of mediators of all this is ApoC-III. So ApoC-III, as I mentioned, when it's larger VLDL gets secreted, ApoC-III attached, it inhibits the conversion to LDL, and you get then transportation or transport of triglyceride in exchange for cholesterol ester by CETP, smaller HDL, smaller dense LDL as a consequence of that. Frank Sachs has shown that ApoC-III on VLDL and LDL associated with increased risk, but without ApoC-III on LDL and VLDL not associated with increased risk. And at the American Heart, we're going to show new data that omega-3s, we have a poster presented that the LDL goes up with omega-3s is the LDL without ApoC-III. That's what happens with a complex mixture of omega-3 fatty acids. So here's our data with EVOLVE. This is a study with Epanova in very high triglyceride patients. Triglycerides were 700 or so, very low HDL, the LDL's below 100, very high non-HDL cholesterol. So this is exactly the high risk, very high remnant cholesterol. See, the remnant cholesterol is very high because non-HDL minus LDL gives you this number right here. So the remnant cholesterol is higher than the LDL cholesterol, and very, very high ApoC-III levels, relatively speaking. So here's the data. With 2 grams a day of Epanova, triglyceride lowering, non-HDL lowering, HDL goes up, VLDL cholesterol goes down, LDL goes up, but the LDL particle size gets bigger as determined by the LDL cholesterol ApoB ratio. If we break it down by what happens to the non-HDL, it is in again, in those VLDL cholesterol lowering effects with LDL, big LDL going up consequently in this study. The ApoC-III reduction was one of the key findings of the trial with both the 2 and the 4 gram dose. So let me show you the data. So here's the tertiles of ApoC-III, so low, medium, and high tertiles. So the higher the ApoC-III, the higher the non-HDL cholesterol, the higher the VLDL cholesterol, and the lower the LDL cholesterol. So again, that's the point. ApoC-III is going to inhibit your conversion of VLDL to LDL, so non-HDL cholesterol goes up, VLDL goes up, LDL goes down with higher levels of ApoC-III. When we added omega-3s, you can see the more effective, the higher the ApoC-III, the higher the percent reduction in non-HDL, VLDL, and increase in LDL cholesterol. So what ApoC-III is doing is lowering that VLDL remnant cholesterol, lowering ApoC-III, allowing that conversion, normalizing that conversion of VLDL to LDL. And there was a high correlation between ApoC-III reduction and LDL cholesterol going up. So let me get back to what I think is going on, because we have EPA and we have EPA plus DHA, and in all the complex mixture omega-3s, we see that ApoC-III levels go down. In EPA-only studies done in Japan, ApoC-III levels did not go down. DHA alone does lower ApoC-III. In a small head-to-head, but high doses, EPA actually did not lower ApoC-III and DHA did. It was not a high elevated C3 population. So there's been a lot of interest in this about DHA versus EPA on lipids. And you can see that DHA lowers triglycerides a little bit more than EPA on triglyceride reduction. But LDL goes up more with DHA than EPA. And HDL also goes up more with DHA than EPA. So could this be explained by differences in ApoC-III between EPA and DHA? So I get to the genomic level, and we look at what do these different fatty acids, how they affect the different nuclear transcription factors. And to quickly go through this, the DHA appears to be affecting more of the factors that are associated with lipolysis, and may be reducing ApoC-III compared to EPA, which is, they both affect SREBP1C. But EPA is more of a PPAR-alpha agonist, and DHA is more affecting these other transcription factors that may be linked more to ApoC-III reduction. So we know that the ApoC-III reduction in animal models is independent of PPAR-alpha. In PPAR-alpha knockout mice, ApoC-III levels still go down with fish oil. And then we look at HNF4-alpha and carbohydrate responsive binding protein. Again, the glucose induction of ApoC-III is involved in these two factors, which are more affected by DHA. So DHA is affecting more of these other nucleotranscription factors that are linked to ApoC-III production that's enhanced by elevated glucose levels in the liver. And this is another comparative trial. This compared EPA, DHA, and DPA, again pointing out that carbohydrate responsive binding protein was not affected by EPA, but was by EPA, but not by but it was affected by DPA and DHA. So EPA had no effect, but DPA and DHA did. And you can see that might be what's more linked to the ApoC-III reduction. Again, all affected by SREBP1C. So I think what might be going on, and FOXO1 is another important target. Again, that's also been linked to DHA only. DHA is affecting upregulation of FOXO1, which then stimulates the ApoC-III reduction by the liver. The other target I was very interested in, to show you I liked FXR as a target. FXR is an exciting therapy now for NASH. It's a bile acid regulator. And omega-3s with DHA, they act like an FXR agonist. So I thought maybe they are an FXR agonist. And so we did a study. So FXR agonism will turn off SREBP1C and ApoC-III and things like that. All the things that you expect you see with omega-3s, you see with an FXR agonist in general. So we did a study in FXR knockout and LDL receptor knockout, double knockout mice. And the FXR knockout mice have higher triglycerides, but it was still lowered with OM3-FFA, which is EPA plus DHA. And we also showed reduction in VLDL primarily. Here's VLDL. This is the FXR double knockout. omega-3 has really lowered it dramatically in the FXR knockout. So it was not. So omega-3s, EPA and DHA together work somewhat independently of FXR. Now, what I wish I could have done, because based on what I know now, I think EPA is not FXR mediated, but DHA may well be. And so we had a complex mixture of EPA and DHA. So we still may not have ruled out that DHA itself is an FXR agonist because we used a mixture of both in this study. And we did see dramatic reductions in atherosclerosis too in this animal model with the omega-3 therapy. So I want to share with you, so these are two studies that were done, one with a pure EPA called the Marine trial. The other was Epanova with a combination of EPA and DHA. You can see how they respond differently. These are done in the same lab, same sites, same CRO. So they were not done head-to-head, but they were done by the same lab and done basically in the same patient population, over 500. You can see that when you use a complex mixture, this is 2 grams versus 4 grams. This is 2 grams twice a day of an ethyl ester. So the bioavailability is also a factor here, but I'm showing you the lower dose here, the lower dose of 2 grams versus 4 grams. Triglyceride lowering is about the same. Non-HDL lowering is about the same. What we're seeing here is the VLDL cholesterol lowering is greater, but you have a shift of that to LDL, which suggests that a DHA EPA complex mixture is providing some additional benefits there when it comes to that increased conversion of VLDL to LDL. So here's what I summarized what I think is going on with EPA versus DHA. So you have this large triglyceride-rich VLDL particles. With EPA alone, you're shrinking those particles. You're having less triglyceride composition, less cholesterol. But with EPA added to that, you get greater lipolysis because you're stripping off ApoC-III, which is inhibiting ApoC-III, ApoE clearance, mediated clearance of these lipoproteins. So this just summarizes this is a well-published table of EPA versus DHA on these different lipid effects. Pure EPA, pure DHA. They both lower triglycerides, but DHA does it more. Non-HDL lowering is about the same, but more so for VLDL lowering here versus LDL going up. LDL particle size gets bigger, HDL goes up, as opposed to no effects with pure EPA. So the point is I like a complex mixture. That's my view. I would prefer a complex mixture of EPA and DHA to maximize risk reduction. So the last point I want to make in the final 5 minutes or so is the outcome trial. So we had a lot of discussion about this outcome trial, and I don't want to share with you the issues about, omega-3 trials have been done at low doses and they've been mixed. I'll show you the data. They're some positive, some negative. Lipid-lowering trials with triglyceride-lowering drugs have been done, but they've always been done in not high triglyceride patient populations. But in the high triglyceride patient population, there's a benefit. And here's the high triglycerides alone, the benefit was very modest in the highest tertile. But when you add in low HDL, you got a very nice benefit, 17% events versus 12% events, which was significant, and the p-value for interaction was 0.06, but still it trended in the right direction for the high triglyceride, low HDL subgroup. Now same for AIM-high. AIM-high was with niacin, 17% events in the control arm, the active arm versus 22% events in the placebo arm, which is an active arm also, all on top of statins. So 17 versus 22, about a 5% absolute event rate. So very, very big absolute event rates in these high TG, low HDL subgroups. So here's a summary of all the trials. They have 7 out of 7 now, showing consistently a benefit in the high TG, low HDL subgroup. It always works 7 out of 7 times in those subgroups. So obviously we picked that subgroup then for our major outcome trial, which is going to get started very soon. So even omega-3s, this is the GWAS trial in Japan, they looked at this subgroup again, high TG, low HDL, and they see a nice benefit in that subgroup, even though it was only a 2-gram dose, which did not have a triglyceride-lowering effect. So again, the subgroup was positive in the GWAS trial. So then the last issue then is, what about a Western U.S. population, an outcome study with omega-3s? It looks like studies that were positive were more in the higher levels of omega-3s. Japan and Italy's around here too. So Italy, I showed you the breast milk study, but Japan's right here. Italy's also in the higher end of the curve. So the positive studies, GISI, DART, GELIS, for example, positive. And we have a lot of negative trials recently that use all low doses, 1 gram of omega-3s. So this is an analysis that was done in JAMA showing positive trend, but when they corrected for the p-value was 0.006, was not positive, but right direction, but only 1 gram of omega-3s in all these trials. So here's our data, just to kind of put it in perspective. So here's the study I showed you, that phase 1 trial. The baseline EPA level was 9.5. And it went to 34 with 4 grams of Lovesa. Remember, we're only giving 1 gram in these trials. So it went from 9 to 34 with 4 grams of Lovesa. The Epanova went to 143. In Japan, the baseline level was 93. So with 4 grams of Lovesa, it went from 34, 1/3 of the Japanese baseline levels. So that's important because in Japan, the benefit was associated with the highest levels of omega-3s are associated with the benefit. We don't get there unless we use something like Epanova, which is much more bioavailable as a way to affect plasma levels of omega-3s. So the last point about this is statins also affect the desaturase enzymes. It's been well documented that statins increase conversion of short-chain to long-chain fatty acids. And so in a U.S. population where you're eating more linoleic acid, you can see that in those that have statins, we saw higher AA levels in general. And unless we gave high doses of omega-3s, do we get even more AA reduction. So that's the other complicating factor is everybody's on a statin these days, and that does affect the arachidonic acid levels in those patients. And the more we lower the ratio, the more we lower triglycerides. So here's the trial. It's 200 to 500 triglycerides, HDL below 40 in high-risk patients. We took about a 6 to 9 month delay because the Predimed study came out and we're using olive oil as our control, and we had to say, okay, oops, we can't use olive oil now as our control arm. We had to switch to corn oil, which we had to make the corn oil placebo. We're not sure that's exactly the right control still today, but it is the control that we're using, and I think we can't think of a better control, to be honest with you, when it comes to this outcome trial. So we're using 4 grams of Epanova, free fatty acid omega-3 versus 4 grams of corn oil in this high-risk population. So let me summarize the implication. So point number 1 is that these FAS polymorphisms, I believe, are very important. And they explain, in my opinion, the differences between Hispanics and African Americans on different cardiovascular risk factors, especially triglycerides and HDL, which are just the opposite in subsets. And also, for African Americans, may explain their risk of hypertension and other more factors that may relate to vasoconstriction and inflammation. Therefore, we need higher levels of omega-3s to affect these different polymorphisms. And that needs to be taken into account when we design these cardiovascular outcome trials. When it comes to the effects of omega-3s, I'm a big advocate for the complex mixture, both EPA and DHA, having, I believe, the best effects on the various lipoprotein parameters. And specifically, if we're going to lower VLDL cholesterol, remnant cholesterol, as a target of therapy, those patients have to have elevated VLDL cholesterol as a prospective design. In other words, we have to have a high TG patients to study. If their VLDL cholesterol is already normal, we're not going to see a benefit with omega-3 fatty acids for that specific target. And that's where the strength trial is going to be. We're going to use a high bioavailable, get the plasma levels of omega-3s as high as the Japanese population. We're going to use the right patient population, 200 to 500 triglycerides with low HDL. And hopefully I can come back to you in 4 or 5 years and present the results of a very positive trial, which has an important implications for cardiovascular disease in this country. So thank you very much for your attention, and we have a few minutes for questions.
Questions?
Yes.
Talk about using for your control a mixture of all that represents what the Americans consume.
So it's really,
And corn oil, because that could be potentially problematic. Corn oil.
so what would you recommend, like a saturated fat?
Yeah, but whatever is the mixture of the regular American
See, this,
diet,
the problem is we have to use what's called USP available, and because you're under pharmaceutical regulations, and so there's only a few things we could use. One is olive oil, one is corn oil, one is migliol, which is like a coconut oil, I understand. Which we couldn't, that's a saturated fat. And the other is mineral oil, which we believe blocks statin absorption. So we felt we couldn't. We had very limited choices. We went back and forth between all those four options, and we ended up with corn oil as the. Could have been soybean oil. It could have been safflower oil, but we end up choosing corn oil. So it was very, very challenging. I wish we had a better solution, but it is what it is. Yes.
So I agree with you on the genetic polymorphism data. I'm just wondering, we're not in the same genetic background, the effect of omega-3 could be disease specific. In other words, cardiovascular disease may be beneficial, but in terms of tumor genesis, it could be enhanced effect. For example, when we did on the animal study, when we give the fish oil, we did see the lung cancer decrease, but at the same time, liver become fatty and NASH.
Yeah.
So that, could be the disease specific or organ specific.
Right. That's why I like the fat. I like that study where they converted the 6 to the 3, because if you give it so much omega-3s, sometimes you make it worse. Like you said, you make it worse in those animal studies. You're right. It's a good point. It's like I'm trying to say, it's more complicated than we realize because of the genomic effects we have on these different omega-3 and other fatty acid levels. Yes.
I'm curious about mouse data because it's clear when you show the human data, it's just serum levels basically.
Yeah.
And I'm especially interested in fatty liver, and especially since if you are altering the secretion of triglyceride, then we don't have the liver data to compare fatty liver if it's affecting if you're getting more fatty liver, if you're decreasing triglycerides, for example. And I guess you have mouse data. I'm curious about the effect of EPA on carbohydrate response.
So you don't. There's been studies in animals showing reduction of liver fat with omega-3s. Again, I think it's the dose. Sometimes you have too much, you get fatty liver, which has been shown. So omega-3s work on the transcription level, so they don't like an MTP inhibitor or they work right at the triglyceride synthetic step where they block triglyceride synthesis. So and that's where they work, and they segment more to beta oxidation. So they block synthesis and they move it to beta oxidation. And that's how I think why they're ideal maybe for the fatty liver type. We're going to be studying it for fatty liver, Epanova. So that's one of our therapeutic studies we're going to get underway relatively soon. Now, data in humans with omega-3s is mixed also for benefit. It's some studies positive, some studies negative. But again, I think a lot of it is the dose. It's an underdose. They've only been giving 1 or 2 grams a day, not a lot, especially in light of what else they're eating. So we're going to study this relatively soon to see what happens. Ernie, yes.
You've done a head-to-head between Epanova, Lolaza, and Vascepa at 4 grams a day.
No, we've only done bioavailability. We've done a head-to-head versus Vascepa, which we're presenting soon. But we see the same. In that head-to-head we did with Lolaza, we saw better triglyceride lowering with Epanova, but these are healthy volunteers. It was better, but it wasn't correlated with levels. So. But the American Heart, we're presenting, we have a Vascepa head-to-head versus for bioavailability, and it is more bioavailable again, but we don't have lipid data because these are normal healthy volunteers. So we don't have that information. So I don't think we're going to do a head-to-head. It's just too hard to do. But it would be nice to do a pure EPA versus a pure DHA head-to-head, just to kind of see how they, in a high triglyceride population.
Plus, we think the DHA may have some benefits for the brain.
Yeah.
Placebo doesn't have.
Right, right. Like I said, I like that. I'd rather have the complex mixture. So that's my view.
Well, Dr. Davidson is going to be available to have lunch with the graduate students and postdocs up on the 9th floor. And please, once again, join me in thanking him.
Thank you.